personnel. It's my pleasure to introduce our presenter today, Kathryn Pears, Chief Operating Officer from the National Task Group on Intellectual Disability and Dementia Practices, or otherwise known as NTG. We have a really good presentation coming up today, and we're really appreciative of Kathryn coming on and sharing so much good information. Thank you, and Kathryn, it's all yours.
Thanks so much, Seth, and thank you, Maddie. It really is an honor to be here with you all today to talk about a subject that I'm really very passionate about, and I've got a lot of information for you. So I will get started with that and hopefully be able to have some time left at the end so that we can take questions. And I would encourage you, if something comes up and you have a question, don't wait to put it in the Q&A box at the very end. Go ahead and pop it in there as the questions come into your head. I know Seth and Maddie are monitoring that. We will do the questions at the end. But if something pops into your head as I'm going along, make sure you get it in there now. For those of you who are not familiar with the NTG, we are really the only national nonprofit organization, 501c3, whose sole goal and mission is to address the needs of aging adults with intellectual disabilities who are at risk of or who have developed Alzheimer's disease or some other form of dementia. And we do all sorts of things. We do federal advocacy, we publish papers, resources, guides. We do a lot of in-person and online training, not just for professional staff, but also for family caregivers, webinars throughout the year. So please do check out our webpage. It's down at the bottom of each of the slides, www.the-ntg.org. Lots and lots of resources on the website, and we invite you to explore those resources. This is just a bit about me. I am Chief Operating Officer for the NTG. I have, close to 40 years, probably a little over that now, personal as well as professional experience with dementia. I got my start back in 1981 when my dad was diagnosed with Alzheimer's disease. He was only 56 years old at that time. And my mother and I cared for him at home for 10 years. We never heard of Alzheimer's disease, to be perfectly frank. And I discovered through caring for him all those years what a rough road this is, particularly for family members, but also for professional staff. And that was kind of a career changer for me. And I started getting more involved with my local Alzheimer's Association, wound up as staff, as Director of Policy and Programs for the Alzheimer's Association in Maine for almost 20 years. And around 2008, 2011, we started getting calls from group homes in the state with providers saying, we've got this aging population and we understand caring for people with IDD, but we've never cared for an aging population. And some of our folks with Down syndrome think maybe they're developing Alzheimer's, but we've never cared for someone with dementia. So I developed a lot of programming around that. Subsequently, after I left the Alzheimer's Association in 2011, started my own training consulting firm called Dementia Care Strategies. And through that and trying to research and learn, does dementia present differently in people with intellectual developmental disabilities than it does in the general population? What's different about it? Are the care principles different? I came upon the NTG and Dr. Matthew Janicki, who's co-president of the NTG and one of the founders of the NTG, and started working with the NTG. And as they say, the rest is history. I was on their steering committee once we formed our own nonprofit. I was on our board of directors. And then we finally grew to the point where we could have actual staff. It was a volunteer effort and a working board of directors up until about 2022. And was very honored to be offered the position, the first staff position as Chief Operating Officer. And as they say, if you love what you do, you never work a day in your life. And I think that's really true for me. Here's the standard medical disclaimer. Don't disregard any professional medical advice or delay seeking medical treatment because of something you hear me say in this webinar. I take great care to ensure that the information that I'm presenting to you is evidence-based or evidence-informed and is accurate, but please bear in mind that this is educational in nature, so don't disregard professional medical advice. And here are the standard learning objectives, and I'm just going to skip over that pretty quickly to get to the heart of why we are here today. The good news, people with Down syndrome specifically and other forms of ID are living longer. And specific to people with Down syndrome, many of you probably recall that back in the early 1940s, people with Down syndrome didn't used to live more than 9 years old. They tended to die from cardiac conditions or infections. And so it's great news. Now they're living to be in their 60s, 70s, and beyond. I was talking to someone the other day who has a client with Down syndrome who's 85. That's probably the oldest person I've heard of, but there may be people out there who are even older. But it's kind of a double-edged sword. You know, as we all age, we are at the mercy of aging-related health conditions. And one of the big ones, particularly for people with Down syndrome, is that risk of Alzheimer's disease. So there's this sort of tsunami off the coast, and older adults with ID are going to continue to grow, and that's a wonderful thing. And many of you who are with agencies are supporting aging people to age in place. I know that's what you all want to do. I have to say, having worked in the long-term care field in the aging network for many years, I marvel continuously at the commitment that folks who work in the disability field have towards caring for people. And so that's always the goal. But more and more, you're running into more people who are aging, not just with Down syndrome, but any other forms of IDD. And so dementia is becoming a more consistent part of how you develop services. And the time to be preparing for this aging population is now. In fact, it was probably many years ago. But if you haven't really dipped your toe too far into this aging population, don't feel bad, you're not alone. There are lots of agencies and organizations around the country who are just now starting to see that their clients are aging and that their needs are changing as they age. So don't feel bad. It is never too late. You know, for people with ID, they have a lot of healthcare disparities right out of the starting box. Medical school physicians, believe it or not, there's no required training on ID in medical schools. There are efforts underway now to change that. One of our board members, Dr. Rick Rader, is actually leading a national effort to require an ID curriculum in medical schools. These things you can't turn around overnight, so it's certainly more slow going than any of us would like, but there are efforts underway nationally to kind of change that. But for now, most physicians didn't get any training at all on ID. And, you know, textbooks don't even have sections on them on aging and ID. And there's not a lot of research out there. The population for whom we see the most research is people with Down syndrome, because that is the group of folks with ID that have that most enhanced risk for developing Alzheimer's specifically. But we don't know a lot about for people with autism or people with cerebral palsy or people with Fragile X or fetal alcohol syndrome. There simply isn't a lot of research being done on those other conditions. And so I wish I could tell you more about how aging and dementia will impact those other forms of ID other than Down syndrome. We can draw some conclusions, but there really isn't any research out there to give us actual answers. I hope that will change. It is unfortunate that most research dollars go to the, well, I shouldn't say it's unfortunate that research dollars go to the younger population, children and young adults. That's a good thing. There's nothing wrong with that. But we should be dedicating like numbers of dollars to the aging population for whom their needs are very different. And I don't need to tell you, there aren't a lot of healthcare providers out there who have expertise in this population. Even when I talk to people in major cities, and I ask the question, do you have good access to specialized care for people with ID here? They almost inevitably shake their heads no. So even in major, you know, hubs, medical center hubs, it's still very scarce. So it's really hard. And because of that, we see a lot of misdiagnosis and a lot of conditions that go overlooked. And one of those is dementia. So let's talk specifically about dementia for just a minute. And I want to kind of set the stage so that we're all on the same understanding. This word dementia is one of the words that I see misused quite frequently. And I want to make it very clear. Dementia is not a disease. We use the word like it's a disease. I have people say to me about their family members, oh, my family member was diagnosed with dementia. Thank goodness it's not Alzheimer's disease. Dementia is not a different disease. Dementia is a generic, general term. Think of it as an umbrella term. And it just describes a group of symptoms, a collection of symptoms. It's like if you woke up this morning and you had this place on your arm and you looked down and you had this red patch and it was itching and it was spreading and it was maybe raised and bumpy, and you look at your arm and you think, what the heck's going on with that? And you go to your doctor or the urgent care and you show them and you say, what's going on with my arm here? And they look at it and they say, oh, you have a rash. Well, I knew that when I walked in the front door. You know, the symptoms of a rash is red and raised and itching and spreading. What do I really want to know? I want to know what's causing it. What's the cause of these symptoms? Because if I know what the cause is, then maybe I'm going to know how to treat it appropriately. Same thing true of this term dementia. It's just a general term for a group of symptoms that describe problems with your thinking, memory, sometimes behavior, and your ability to function in your everyday life. And there are all kinds of conditions that can cause those symptoms, some of which are actually treatable, or some are even reversible. They're not all Alzheimer's. There's a saying that all Alzheimer's is dementia, but not all dementia is Alzheimer's. And that's important to understand, because there are a lot of potentially treatable or even reversible conditions whose symptoms mimic the symptoms of Alzheimer's, but they may be treatable or even reversible. And for people with Down syndrome, this is particularly important for anyone with any form of ID to understand this concept, but especially for people with Down syndrome, because there is a pervasive belief out there that 100% of people with Down syndrome are going to develop Alzheimer's. And that's not true. So again, you know, what are the common symptoms of dementia? For most forms of ID, and true of the general population, short-term memory loss is the first thing you see. Asking repeated questions, telling the same stories over and over again. For people with Down syndrome, we don't as much see that short-term memory loss as a presenting symptom. We tend to see more personality changes. We tend to see people with Down syndrome having a change and wanting to engage in activities that they used to enjoy, maybe withdrawing more. Changes in judgment and ability to reason, changes in communication, the loss of previously learned skills. For people who used to be able to dress themselves independently, now we're seeing they have trouble dressing themselves. And specifically for people with Down syndrome, the onset of seizure activity. That, for people with Down syndrome specifically, can be a red flag that it could be the onset of Alzheimer's. But again, you would never want to immediately jump to that conclusion without going through a thorough evaluation. And I'm going to talk to you about what that means in just a couple of minutes. As I said before, people with Down syndrome, they have the highest risk of developing Alzheimer's disease, and that's because of that third chromosome 21. And that's the chromosome that is responsible for production of the amyloid precursor protein. And that is the protein that causes the plaques and tangles of Alzheimer's disease specifically. So because people with Down syndrome have that third chromosome, they get an extra dose of that risk factor for developing Alzheimer's disease. And so it's important, particularly for people with Down syndrome, to start monitoring them earlier, because they are going to develop Alzheimer's earlier than the general population, or even earlier than people with other forms of ID. So again, It's important to remember, not 100% of people with Down syndrome are going to develop Alzheimer's, but they do have a dramatically increased risk because of that third chromosome and that overproduction of the beta amyloid protein. And we do know that by the time someone with Down syndrome reaches the age of 40, if we were to do neuroimaging of their brain, we would see the plaques and tangles characteristic of Alzheimer's. But the symptoms probably are not going to show outwardly for another 10 years or so. So just having that pathology doesn't mean they have the outward symptoms yet. By the age of 40 to 49, these are, based on studies, 23 to 55% of people with Down syndrome will have, the symptoms of Alzheimer's, those plaques and tangles. By the time they reach 60, note that percentage goes up, and by the time someone reaches 60 to 70, maybe up to 88%. The saying is that the lifetime risk probably exceeds 90%, but it depends on what study you show. Some studies show a lower risk, but it's not 100%, and that's the takeaway. For people in the general population, the biggest age of risk is from the age of 65, 70 on up. And for people, there are, fortunately rare, but there are people who have a genetic form of Alzheimer's disease. They do develop Alzheimer's at a younger age, 45 to 65. You'll recall I said my dad was 56. He was adopted, so I don't know what his family history is. I'm happy to say I am considerably older than he was when he was diagnosed. I like to think most days my ability to think is still functioning pretty well. So I don't know if it was a genetic thing with him or if something else caused him to develop Alzheimer's. It was confirmed after he died by an autopsy of his brain, so we do know for certain that it was Alzheimer's. But look at people with Down syndrome. They're going to develop those symptoms from the, early to mid 50s. So again, for people with Down syndrome, they're going to develop those outward symptoms and those changes anywhere from 20 to 30 years earlier than we would expect for people in the neurotypical population. What about people with other forms of ID? As I said earlier on, we don't really know. Some studies show they have rates similar to the general population over the age of 65. Other studies show they may have higher rates of developing dementia, but again, it really isn't being studied. So we just can't tell you with any certainty what the real risk is for people with other forms of ID. And, frankly, I suspect there are people with other forms of ID for whom they may have developed some form of an irreversible dementia, such as Alzheimer's or Lewy body dementia, frontal temporal dementia, vascular dementia. But because of the communication challenges they may have had over a lifetime and other co-occurring health conditions, it maybe is not being diagnosed. The problems that we're seeing in the individual, the changes we're seeing in them, it's called diagnostic overshadowing, gets written off as the underlying disability instead of a recognition that they may be developing some form of dementia. So it's hard, and research is ongoing, but we need a lot more. So what becomes key is identifying early warning signs. And as I said, for people with Down syndrome in particular, but probably true of other forms of ID, the onset of dementia often looks different. For instance, for people with Down syndrome, that memory loss may not be the first thing you see. You might see seizure onset as the first thing, or they don't want to engage in activities that they used to enjoy, or they're seeming more withdrawn, or you're seeing behavioral changes, so becoming more easily agitated or upset. And again, because they have an underlying disability, sometimes that masks these new concerns, and we just tend to write it off as, well, that's their Down syndrome, that's their autism. I mean, look at people with that are autistic individuals who have sensory processing difficulties already. We know with the onset of dementia, people develop sensory processing issues. Is it the autism? Is it the onset of dementia? Difficult to say. again, as I mentioned, we're drawing from activities they used to like, increasing anxiety, changes in personality, sleep disturbances, declining independence. These are all things that you might see that could suggest it's the onset of some form of dementia. But you'd never want to make that leap until you do your due diligence and get a good differential diagnosis. And we will, as I said earlier, we're going to talk about what that means. But what you need to do, and what I highly advise you do as an agency or an organization, is establish a baseline for everyone that you have, all the clients that you have that are at least the age of 40, particularly if they have Down syndrome. And what you want to do is start looking, and when you see a change, say, is this different from their usual pattern? That's going to help you. That documentation is going to help you with your planning down the road. It's going to help with earlier detection, whether it's a form of an irreversible dementia or a treatable form. If it's a treatable form, obviously we want the person to have the benefit of a therapy, if there is one, that could reverse those symptoms. So understanding the person's baseline is a really important issue. And, as the saying goes, how do you know what's changed if you don't know where they started? And this is a huge challenge for people with IDD. Again, oftentimes pre-existing cognitive impairment makes those standard tests that would be used if you or I went to our physician's office and, we were there because we had some change in our ability to think or some personality changes. The first thing the doctor would do would be administer a brief cognitive screening assessment. That would be something like the mini mental status exam, or there's a bunch of different ones, the MOCA or SLUMS. There's a whole bunch of them. And those work very well in the general population, not to diagnose what's causing the changes, but to just say, okay, yeah, something's not right with your thinking. We need to take some next steps and see if we can figure out what's causing those changes. But for people with ID, these are tests that ask you things like count back from 100 by sevens. Well, if I've never been able to count back from 100 by sevens, I'm going to score low right off the bat. Clock face, drawing the clock face is a very familiar one, and putting in the hours in the appropriate spaces, and then the hands of the clock and setting them to a specific time. If you've never been able to do that, you're going to score low. So it can that end result, and somebody might think that you were far more impaired than you actually are, just because you are being administered a test that isn't appropriate for someone with ID. These tests, mini mental status exam, SLUMS, all of those rely on they're normed in the neurotypical population, not in people with ID. And they rely on a certain level of verbal ability and comprehension, certain level of IQ, certain educational attainment. I talked to a mother recently whose daughter was administered one of these tests. And one of the pictures they showed her and wanted to identify was a picture of a cigar. And her daughter had absolutely no clue what a cigar was. She had never been exposed to it. She had Down syndrome. She'd lived with her family her whole life, had led a fairly sheltered life, and she didn't know what a cigar was. So she scored low right off the bat because of that one thing. And staff changes. If you have someone who's lived the majority of their life in a congregate setting, staff changes. Sometimes that historical information doesn't get passed on. And again, that diagnostic overshadowing, attributing changes to the underlying disability instead of saying, oh, wait a minute, this person's aging. I wonder if something else could be going on here. So that's why establishing this baseline level of their functioning before someone gets to the age of 40, regardless of the form of ID they have, is so important. I'm going to suggest a tool in the middle for you in a minute for you to use. It's called the NTG Early Detection Screen for Dementia, NTG EDSD for short. But before we look at that, I want to tell you some of the domains that we want to be looking at to see if there are any changes in these from the person's own baseline. We want to look at their cognition, just a fancy word for thinking, and their memory. Are they having trouble finding their way in a familiar place? Are they getting lost in a familiar place? Maybe having trouble finding their way to their bedroom or to the bathroom. Are they having trouble learning new information? Are they repeating questions, repeating stories, those sorts of things? We want to look at someone's language and communication ability. Are they having trouble finding words? This, of course, assumes that they have been verbal. Not everyone with ID has, the same level of verbal skills, but assuming that they have previously been verbal, are they now having trouble finding words? Is their vocabulary decreasing? Are they having trouble following conversations and seeming more confused in a conversation than they used to? What about their behavior and their personality? Are they withdrawing? They seem less interested in activities they used to like. Are you seeing increased anxiety? Do they look afraid in situations they wouldn't have in the past? Are they seeming maybe depressed or changes in their mood? Are they crying or things of that nature? Are they increasingly agitated or irritable appearing? Changes in their sleep patterns. Maybe they're getting up at night and starting to wander around, or they're sleeping all day. Do they appear to be more suspicious or paranoid? And then their functional abilities. Whatever their level of self-care skills were in the past, is there a change from that now that you're noticing? Are they having trouble doing familiar tasks at work or at home that they used to do very easily? Are you seeing a change in their eating habits? Or are they maybe developing some incontinence when they were never incontinent before? And again, for people with Down syndrome specifically, the new onset of seizures. Now, people with dementia may develop seizures, but they usually do so later on. So specific for people with Down syndrome, that onset of seizures very, very early on, that could be a red flag that it could be the onset of Alzheimer's. But again, you wouldn't want to leap to that conclusion without doing some more due diligence. So here's the EDSD. This is a free tool. It is available on our website for you to download. It is now in 18 plus different language translations. There's a little manual that comes along with it, very brief, but tells you how to use it. We also have some one-page guides. We have one for physicians, one for family members, one for staff, and one for self-advocates. And again, the beauty of it is not only that it's free, that's a benefit, but also that you don't have to be a clinician to do this. A family member can do it, a DSP can do it, anyone can do it. We do recommend that it be completed by the person who has the longest knowledge and experience with the individual, but you don't have to have a clinical background to do this. I do, again, want to emphasize this is not a diagnostic tool, and it's not a replacement for a comprehensive medical evaluation. When you complete the tool, it's several pages, but when you complete the tool, you're not going to add up numbers and come up with a score. It's going to say, oh yes, this person has Alzheimer's disease or some other irreversible form of dementia. That's not what it's designed to do. It's a screening tool, simply designed to tell you something has changed from this person's baseline. So you would do it. Let's say you have people in your client load now that are over the age of 40. You would do it with everyone over the age of 40, and you do it on an annual basis. Pick a date that works for you, their birthday, the first of the year, whatever date makes sense for you and your organization. And you do it the first year, and you may not see anything that raises an alarm. And you do it the second year and nothing changes. Maybe now the third year, the person's aged a little more, and you start seeing some check marks in some of these columns. And that would be the indication that something has changed from this person's baseline. Now, if you have people that are diagnosed with some form of dementia already, still do it with them, because it will allow you to track changes over time that may be helpful to you. So it's a really good tool to systematically document concerns and changes over time. And you can use it to be what we refer to as a communication bridge between caregivers and your healthcare providers. And again, it's a very intuitive tool. It's very easy to use. It's in widespread use across the country now. Some of your organizations are perhaps already using it. There are a couple of states that require the use of it. I know we had just recently a neurologist in Texas attend one of our workshops, and he is involved with all the state-supported living centers in Texas. He's looking to implement it in the state-supported living centers there. So it's in widespread use internationally as well, actually, not just in this country. So it's had a lot of use, and I can tell you that the organizations that are using it have found it to be incredibly helpful to them. So I would really suggest that, you visit the website and download it and give it a try. Again, ideally, the person who knows the individual best would complete it. If someone is let's say they go to a day program during the day and then they go back to a group home or their family home at night, I would suggest that you do it in both locations because people can look very different during the day than they do in the evening. For someone with Down syndrome, we would suggest mid-30s, but at least by the age of 40. And for people with any form of ID other than Down syndrome, at least at the age of 40. And again, this is going to track scores, and you can use it as a basis for requesting further identification once you identify that there has been a change in the individual. I don't have time to walk us through it page by page today, but there are links on our website to prior webinars that explain it in more detail. And if anyone would like more information, I'm happy to provide it to you. But there is a lot of information on our website how to use it specifically. So when you've done your EDSD, and let's say you've been doing it for several years, and you're noticing that you're getting some check marks in those columns that are there, and those columns are marked. One of the columns is marked new change in past year. And so maybe now you're starting to see some check marks, new change in the past year, and some of those domains we talked about a minute ago. Those are kind of the red flags that you need to do some further evaluation. And so you would want to use this tool as a conversation starter. Remember, this isn't the final answer. This isn't going to say, oh yeah, they've got Alzheimer's disease. What it's going to do is just tell you something's different. Something has changed. And I do want to just talk very briefly about this condition called delirium. Delirium is a medical emergency. Delirium is a sudden change. Most forms of dementia come on very slowly and insidiously over months and years. Delirium is something that comes on very suddenly. Yesterday, the individual was whatever is normal for them. And today, something's really different. They either don't want to get out of bed, they don't want to talk, they don't want to eat, they just want to sleep for hours on end. Or conversely, they get out of bed, but they're very agitated and they're pacing, and you can tell they're visually agitated. That's a change. So a sudden change, either hypoactive, hyperactive, or fluctuating between the two, is probably delirium, and that's a medical emergency. There can be multiple reasons why someone develops delirium, but urinary tract infections are one of the most common reasons. So you would want to rule that out first and foremost. But fecal impactions, pneumonia, medication side effects rather, there's a long list of things you could rule out, but look at urinary tract infection first. When I was in Maine, Dr. John Campbell, who at that time was the head of the Geri Psych unit at Maine Medical Center, told me that for people admitted through the emergency room at Maine Medical Center for, quote, agitated dementia, 95% of them had urinary tract infections. That's how common it is. So I would say first and foremost, you see that sudden change, rule out a urinary tract infection. People can develop sepsis very quickly, and I have seen people die from undiagnosed urinary tract infections that were written off as being either part of their underlying disability, or if they already were diagnosed with dementia, someone just assuming it was a progression of their dementia and not recognizing a medical emergency. So what is a differential diagnosis? Differential diagnosis, just a fancy term for when several conditions might have the same symptoms. How do you tease out, what the actual cause of those symptoms are? So medical conditions, hypothyroidism, very common in people with Down syndrome. You would want to rule that out. B12 deficiency, very common in people with Down syndrome. You would want to rule out a B12 deficiency. Infections, I just mentioned UTIs, delirium. Diabetes, if someone's blood sugar is too high or too low. Sleep apnea, if someone, again, very common in people with Down syndrome. If you're going without oxygen to your brain for periods in the course of the night, that can cause damage that looks a lot like Alzheimer's, but might be just sleep apnea. And that's very common for people with Down syndrome. Sensory changes. If I can't see clearly or hear clearly, I might appear to be confused. People with Down syndrome have shortened ear canals. Wax impacted in their ear and they can't hear. They could look confused enough that we might be tempted to think, oh, gee, I wonder if it's the onset of Alzheimer's, and it's wax. Vision changes as we age, developing cataracts, macular degeneration, all of those sorts of things. If I can't see clearly, I might lose my way trying to get somewhere. So when was the last time the person's vision was changed? Their hearing, vision was checked. If they wear glasses, I know I have to have the prescription changed to my glasses almost every year now. When was the last time the prescription was checked? When was the last time their hearing was checked? Pain, dental problems, dental issues are very common in people with all forms of ID, sadly. Could they be having a toothache? Could there be, problems, with their dentition that's causing them pain? Constipation, fecal impaction. You can get really sick. And as we all age, sometimes we develop arthritis. And of course, again, back to people with Down syndrome, osteoarthritis, osteoporosis are quite common. Could they have bumped into something and fractured a bone? If they can't tell you because the individual has impaired verbal skills, you might not pick up on the fact that they could be in pain. Severe depression is oftentimes called pseudo-dementia. Has there been a recent significant life event that this person has experienced? Loss of a family member, maybe even just change in staffing. Maybe a long-term staff member has retired. People with Down syndrome, again, I know I keep going back to that population, but it's the population that we know the most about. But we know that people with Down syndrome oftentimes grieve in a manner that might not look to us like grief, and it can be oftentimes delayed grief. Any major changes, change in their living situation, medications, side effects, polypharmacy. Polypharmacy is a huge issue for this population. And all medications have side effects. And I see people with ID that are on 20 medications. Sadly, it's not that uncommon. And so could it be medication side effects? It's particularly a class of medications called anticholinergics. And they're very common medications. Benadryl, somebody who takes Benadryl to be drowsy and sleep at night. Someone with overactive bladders, they take Detrol, Ditropan. Those are anticholinergics. There's a whole list of them. Antipsychotics are anticholinergics. And those medications alone, particularly if they're taken long-term, can cause cognitive impairment because they lower the availability of a very important neurotransmitter in the brain called acetylcholinease. And oh, by the way, that just happens to be the neurotransmitter that is damaged by the plaques and tangles of Alzheimer's. So you can see how some of these things look a lot like Alzheimer's, but they're not. So, get a good medication review. And I recommend you go to a local pharmacist, not the physician. Go to the local pharmacist. See if they can identify any medications that could be problematic, causing the changes. Again, social changes, life changes. Maybe they had to retire from their job, trauma, any of those sorts of things. We saw a lot of this during COVID when people weren't able to get out as much. And delirium, we talked about that one. So one of the tough things I think is oftentimes to figure out, is it depression or dementia? And very quickly, there is a distinction. For people with depression, what we see is, oftentimes it's more rapid, certainly, because as I said before, dementia comes on gradually and kind of insidiously. But the person with depression, they may complain that they can't remember, whereas the person with dementia, they're not even aware that they're having problems. And the reason they're not aware, it's not denial, it's because the part of the brain that gives us awareness and insight, that frontal temporal lobe, is damaged very early on. So they even lose insight into the fact that something's going on. So if someone is complaining that they're having problems with their thinking and their memory, that's probably not the onset of dementia, but could be depression. And effort is another thing. Someone with depression, if you ask them a question, they may answer, I don't know, that kind of quote, poor effort. Whereas the person with dementia, they may really try and answer your question, but they just can't think it through enough to get to the answer to give you. And also, sleep disturbances for depression, may be disturbed. People may sleep a lot, or they may sleep too little. People with dementia oftentimes have that disruption in their circadian rhythm. So they wake up in the middle of the night and they think it's daytime and they want to get up. Whereas for the person with depression, it could be too much or too little. But you always want to rule out depression because that is treatable. We know there are medications that can positively impact that. So you would never want to write off the person who has some severe depression with being, well, they have Down syndrome, so it's the onset of Alzheimer's disease. And I do see this happen a lot. And again, that diagnostic overshadowing, beware. Don't let these new symptoms be attributed to the fact that this person has Down syndrome or autism or cerebral palsy or whatever, without doing your due diligence and saying, what else could be causing these symptoms? Don't overlook those medical issues. We're talking about a group of people who oftentimes have a lot of co-occurring medical conditions. Not everyone does, but some do. Could it be, a problem of long standing? Look in the medical record. What do we know about them? Their past diagnoses. And, we don't want to delay treatment, particularly for those people for whom there is a potentially treatable reason that you're seeing these changes. So what should be included in a thorough differential diagnosis? A detailed history from the person who knows the individual well, the EDSD, print it out, take it in with you, and take the little one-pager that goes along with it for physicians, because the physician may not know what the EDSD is. So you can take the one-pager with you so that it will explain what it is. In my experience, physicians really like the EDSD because it is very visual, it's very intuitive, and they can see right away what's changed with the individual, and that can really help them narrow down very quickly, because these days we don't have very much time with our physicians, and that can help them narrow down, what do I need to do to start figuring this all out? Lab tests, thyroid, B12, metabolic panels, CBC, liver kidney function tests, all of those things to rule out some sort of a underlying medical condition. The medication review, critical if someone's on multiple medications. Sensory screening, have their vision checked, have their hearing checked. Could there be something there? Again, is it severe depression? Has there been a recent significant life event that could have thrown them for a loop? Maybe neuropsych testing, but only if it's tests that are specifically for use with people with IDD. There are some tests that would be appropriate, but not all. So you'd want to make sure whoever was administering the tests knew what tests would be appropriate for someone with IDD. Maybe an MRI or a CAT scan. One good reason for those is a condition called normal pressure hydrocephalus, NPH for short, buildup of cerebral spinal fluid in the skull, causes pressure on the brain. That is potentially treatable if caught early enough. Can put in a shunt, drain the fluid off, relieve that pressure. I have run into a number of people with Down syndrome with normal pressure hydrocephalus, but the initial symptoms do look a lot like the onset of some form of dementia. People with normal pressure hydrocephalus sometimes walk with a little bit of a shuffling Parkinsonian gait. Also may have problems with urinary incontinence very early on. Those could be kind of a signal that it could be normal pressure hydrocephalus as opposed to some form of dementia. But that would be one reason for an MRI or a CAT scan, although we don't see them done as commonly in people with ID as we do in the neurotypical population. We want to look at their daily living skills. What are they having problems with? And again, a sleep evaluation oftentimes, particularly for people with Down syndrome, for whom sleep apnea is very, very common. So how do we support people? Let's assume someone has been gone through the differential diagnosis process, and we're pretty sure it is Alzheimer's. We've ruled out any of those treatable conditions to the extent we can. What do we do next? Well, first and foremost, we want to maintain their dignity. It's very sad to me that once people develop Alzheimer's or one of those other irreversible forms of dementia, we start to treat them differently. We kind of forget, I think, sometimes that that person is still in there. The person still looks the same on the outside. We forget they have this disease going on in their brain that's impacting their ability to think. There are behaviors that may arise. Some behaviors can be very scary sometimes, very agitated, even combative. I could do a whole session on behaviors, and I wish I had the time to do it today. But people with dementia don't see their world the same way you do. They have heightened threat perception because of damage to the part of the brain called the limbic system. A lot of behaviors you see in dementia are, I think, really very reasonable and rational responses to how the person is experiencing the world around them. But it makes me very sad. I have family caregivers who will say, well, at what point in the disease is my family member going to become violent? Because we hear those stories. We see them, this played out on TV and other places. And my answer would be maybe never. A lot of it is caregiver education and training. Talk about that in a minute. Quality of life should always be the first concern. And preserve meaningful activities. Maybe that person always loved to paint watercolors, and they used to be able to do really nice watercolor paintings. And now they've developed dementia and they can't paint quite so well. The end product isn't what matters. What matters is the individual is contentedly involved in an activity they used to really enjoy. So modify the activity. Don't take the activity away. How can we modify this activity so that the person can continue to enjoy it? As caregivers, we may need to spend more of our time setting them up for success, getting the things out that they need to use, maybe supervising them if we have to, maybe sitting next to them and kind of working with them on something. But there are ways to do that. And stress reduction is important. People with dementia are very, very at risk of overstimulation and can have very catastrophic meltdowns when they're overstimulated. So we've got to be aware of overstimulation. Too many sounds in the background, too much movement, people talking in long sentences, too many people talking together. People with dementia, we really have to kind of slow everything down. And I think of this particularly in the context of adult day programs. For where there may be a lot of activity. Do you have a quiet room you can take the person to so they can sort of decompress if we see them starting to become agitated? And I cannot stress enough, becoming a good observer. Oftentimes we as caregivers miss that person communicating to us that something is bothering them until it has become sort of catastrophic. And so becoming a good observer, and if you start to see the person looking like they're getting uncomfortable, that would be the time to maybe move them to a quieter environment if you have it, or headphones with their favorite music playing to block out some of the sound and the noise that could be upsetting them. It requires a shift in our philosophy. Historically, as IDD providers, you've been taught you need to build skills and promote independence. Well, when someone develops one of these irreversible forms of dementia, independence is, didn't mean to do that. Independence is something that's going to shift, and we're not going to be building skills. We're going to be trying to maintain existing skills as long as we can, but knowing that they're going to be losing those skills. So supporting with someone with dementia becomes, how do we adapt activities? How do we adapt how we approach the individual? Those sorts of things. Keeping comfort in mind first and foremost, emotional comfort and physical comfort. And how do we promote the best quality of life that we possibly can for the person? First and foremost, if you're talking with someone with dementia, remember, when we talk about communication, only 7% of communication is the words we speak. 93% of it is your tone of voice and body language. So speak clearly, use as few words as possible, very short, very simple sentences. Try and tap into whatever the underlying emotion is the person is. Are they scared? Are they feeling threatened? Provide reassurance. Speak in a soft voice. A loud voice from the caregiver can convey anger. So a soft voice, and empathize with them, reassure them. And maintaining a familiar routine, extremely important. A change in routine is a real bugaboo for people with dementia. So again, that consistent routine, reduce noise levels to the extent you can. Have a quiet room if it's possible. It's not always possible, but if it is, increase lighting. People as we age generally need 30% more light than someone who's younger. So increase lighting, that can be very helpful. Reduce visual clutter. The person with dementia, if they're looking at a bathroom vanity with all sorts of stuff over it, they may not be able to pick out what's the toothbrush and the toothpaste. And so they may go in to brush their teeth, turn around and walk right out, not having done it. But they can't tell you because of the impaired communication that comes with dementia. They won't be able to tell you that was the problem. And familiar surroundings, trying to keep surroundings as familiar as possible. This is a great resource here, enabling environments. They have some interactive settings that you can go through, and it will give you very specific advice about how much lighting, what type of lighting, and they go through every room and look at everything you can imagine in the room and tell you how to modify the room environment to be more supportive of people with dementia. It's a great resource. Highly recommend you check it out. Wandering, this is going to be an issue. We know that statistics say 70% of people with dementia will wander at some point, but I would tell you if they can walk, they will wander, and they are not going to give you any forewarning. How are you going to keep someone safe? In long-term care, we can lock egress. Not so easy to do it with the regulations that you all have to live under. How are you going to keep someone safe? Do you have overnight awake staff? What if the person gets up in the night? They might wander out. What are you going to do in those scenarios? Or if they're awake all night, are they keeping other housemates awake? Staffing needs. Are you going to be able to increase staffing needs to provide the one-on-one assistance that someone with dementia is going to need as the disease progresses to the later stages? And aging in place may be possible, but you should never assume that it is possible. It's great if you can do it, but it isn't always possible. I would beg you never to promise a family when their family member is diagnosed with some form of irreversible dementia, not promise them that you will care for them till the end. I think the best you can say is we'll do our best, because once you promise you'll keep them, the family is not looking into any other alternatives. They don't have a plan B or a plan C. And if you get to the point where you simply don't have the staffing or the resources or the physical environment to appropriately care for the individual anymore, the family won't have made any plans. And that's doing them a disservice. So we do it for the right reasons, but I would urge you to think about how you approach that question if a family member asks you. And end of life planning. Alzheimer's and these other irreversible dementias are terminal illnesses. And the last part of the brain in Alzheimer's to be impacted is the brain stem. Oftentimes we see swallowing problems because the loss of the swallowing reflex occur. If you do see swallowing problems, I always recommend you have a speech therapist brought in to do a swallowing evaluation. It's non-invasive, it's covered by insurance. They can tell you if the person's just kind of forgetting to swallow, maybe they're holding food in their cheek, versus whether it really is the loss of swallowing reflex, which would be an end-of-life issue. Feeding tubes are not recommended for people at end-of-life dementia. Specifically. Now, there are people that are younger that have feeding tubes with ID. I understand that. That's a different situation. We're talking about people with end-stage dementia for whom the part of the brain controls all of your non-voluntary body systems, your heart, your circulation, your digestion, your blood pressure. That part of the brain is damaged, and it is end of life. The body is shutting down. Questions. Is your staff trained? I cannot emphasize enough the importance of staff training. We do a lot of staff training at the NTG, and I can tell you one of the most important things you can do is make sure your staff is trained in how that shift in philosophy of care from how they've traditionally been trained to support people with ID. Now with the onset of dementia, those Care goals change, and our approach has to change. And it's much too involved to get into in the short time we have today. But staff training is the best thing you can do. And I promise you, there's lots of research that shows that one of the most prominent reasons for staff turnover is caring for people with dementia. And staff training can make it much easier for your staff, much less frustrating for them, much less concerning, and hopefully maybe could reduce your staff turnover. Track your baselines for everyone in your census using the EDSD starting at least by the age of 40. Think about your dementia capable policies. What do you do when someone wanders? Those sorts of things. What are you going to do if someone's not appropriate to continue going to a day program any longer because it's too overstimulating? What are your options? And other partnerships in your community that you can invoke with other organizations who can maybe help support you in this journey. So 6 things you can do tomorrow. If you don't already have one, start an aging committee. Think about your staff education. What do you need to do to upskill people with dementia care skills? Start that EDSD for baseline monitoring. Look at people's medication lists. If you've got people on long lists of medications, get med reviews, see if you can back any of those down or substitute some of those anticholinergic medications. Look to build partnerships across the network and develop a plan. So again, I am going to stop at this point because we've talked about all these things. And with that, I'm going to turn it back to you, Seth. We've got a few minutes, a lot of material, and I was doing my best to get through, and I know we're really short on time. And I would invite you, Seth, if there are questions we can't get to, if you want to submit them to me after the fact, I'd be happy to provide written responses and send them back to you.
That was fantastic, Kathryn. We received many messages in the Q&A box just thanking you for the information. People are going to pass it along to their staff. It was just excellent. Well, like you said, we only have a couple minutes, so I'll toss in probably one question, maybe two. What are some ways that support staff and families can work together in better detecting dementia and supporting people if they have it?
Well, again, I think the EDSD can be your best friend. And starting earlier, and we say at least by the age of 40, you could start in the 20s if you want to. I should say that under the age of 40, Alzheimer's disease specifically is very, very uncommon. I never say never, but highly unlikely under the age of 40, someone's developing Alzheimer's. But do that EDSD so you've got that baseline established, and then use it every year so you're starting to track. And then when you do start to see some changes, that's going to be, your warning sign. Something's changed in this person. Now we got to figure out what's causing the change. And that's where that thorough diagnostic, differential diagnosis comes in. And, medications, I'm a big bug on for this population. So if you've got people who are on lots of medications, see if they're all necessary. I see people on multiple antipsychotics, and sometimes with multiple doctors. Dr. A doesn't know what Dr. B has prescribed, and all of a sudden you're kind of off to the races. And I think that polypharmacy is a huge issue for this population. And again, once someone develops dementia, and this is true of family caregivers as well as professional caregivers, knowledge is power. Learn as much as you can. Workshops, webinars, become a student of these things. Be curious. Remember, behavior for someone with dementia is a form of communication. All behavior has meaning. You have to look at it as a symptom of something going on under the surface. So, educate yourself on behaviors and what can trigger behaviors. So learn as much as you can, and that will be your best friend. Thanks, everybody. Really appreciate it. It's been great.